Welcome to Chapter 44, Sensory Stimulation. The objectives of today's audio lecture is to describe the components of the sensory experience, discuss the role of the reticular activating system in the sensory experience, identify nursing actions that prevent sensory alterations, and assist patients with sensory difficulties. The sensory experience. Sensory reception. Sensory reception is the process of receiving data about the internal or external environment through the senses. There are various types of senses, which include visual, which of course is the vision, auditory, which consists of hearing, olfactory, which is smell, gustatory, which is taste, tactile, which is touch, stereognosis, which is to perceive solidity of objects. It's the sense that there are sizes, shapes, and textures. And kinesthesia and visceral, which is basic internal orienting of systems. Sensory perception. When you talk about sensory perception, you are talking about the conscious process of selecting, organizing, and interpreting data from the senses into meaningful information. Stimulus. Stimulus is an agent or act or influence capable of initiating some sort of response by the nervous system. A receptor which must receive stimulus and convert to the nerve impulse. So or sense organ, that's what a lot of times they'll call, must receive the stimulus. The nervous pathway to the brain from the receptor to the brain. The nerve impulse must be conducted along that nervous pathway from the receptor or sense organ to the brain. A particular area in the brain must receive and translate this particular impulse into what they call a sensation. Reticular activating system. The nerve impulses from all the sensory tracts reach the reticular activating system, or what they call the RAS, which then selectively allows certain impulses to reach the cerebral cortex and be perceived. This extends from the hypothalamus to the medulla, and it mediates arousal primarily. So the nerve impulse from all the sensory tracts, they reach the RAS, and which then they selectively allow certain impulses to reach the cerebral cortex where they are perceived. Then the mesencephalic portion of the RAS appears to be what they consider the center of the system, and the stimulation of this area produces the most pronounced and long-lasting effects on the cerebral cortex. So with its many ascending and descending connections to the other areas of the brain, the RAS serves to monitor and to regulate incoming sensory stimuli, thus maintaining, enhancing, or inhibiting cortical arousal. So that's what the state of arousal or awareness, and that's how it's described. So basically, here is just a picture of the RAS system. So as a result, you have different what they call states of awareness. Most individuals have what they call conscious or they have unconscious. So conscious. I want you to be able to distinguish the difference between conscious and unconscious states of awareness. Conscious consists of delirium, dementia, confusion, normal consciousness, somnolence, chronic and vegetative states. Unconscious consists of asleep, stupor, or coma. So, to give you like an examples, um you have to know that a person can be conscious but they could be in a state of delirium. What's an example of a state of delirium? It's when a person is disoriented, they can be confused or something like that, but they're still in a state of delirium. You have dementia, where people have problems with confusion or something like that. Sometimes people have some somnolence or chronic vegetative states. What is somnolence? What is that? It's extreme drowsiness, but they will still most of the time respond to what they consider a normal stimuli, or they can have chronic vegetative states. Um, so it's very important. Um, oh, excuse me about that. The chronic vegetative state, a lot of times they put that up under unconscious states. I forgot to change that slide, but I'm going to tell you that chronic vegetative state, because if you look at the definition where they can't be aroused and they don't respond to certain um, stimuli, and the fact that a person may like they may often respond like they'll have like what they call non-purposeful movement, which means they'll have random smiling or random grimacing, but it really doesn't mean anything. So put that under unconsciousness. I want you guys to do an exercise, and I want you to think of certain incidences and certain examples of what a person would be considered in a conscious or unconscious state. I can give you an example. An example. I went out to see some friends of mine. We had one of them little sorority things. We were playing around, having a great time. We drank, we did, I have to admit, we were like, drunk and everything. And then you have um your designated driver, the person that's in your sorority that doesn't drink. So that person goes around and they're dropping everybody off. Okay, so, and even my sorority sisters to this day still tease me about this. So they drop me off, and I asked them, as I'm getting out the car, I asked them, I say, oh, did I eat today? And I mean, tonight? And then they was like, yeah, you ate. We went to White Castle or wherever we went or wherever you go. And I told them, I said, oh, great, because I don't want to go to bed hungry. Would that be considered me being in an unconscious or a conscious state? So think about that. Okay, next slide. Factors which contribute to sensory alterations. Okay. Factors that contribute to sensory alterations. Okay. sensory deprivation. So, decrease in sensory input. Conditions that lead to sensory deprivation, so are environment with decreased or monotonous stimuli, which means that you're not getting that much stimuli, um, or you're getting that same, which is monotonous, the same stimuli all the time. Okay, so basically, if that is what really leads to what a person called sensory deprivation, impaired ability to receive environmental stimuli. A person that has impaired uh, ability to receive environmental stimuli might be because something's not working right. Maybe they're blind. Maybe they have some type of numbness or a stroke or whatever, or maybe cognitively there's something going on. Inability to process environment stimuli, that deals with them cognitively not being able to receive. A lot of times when you have individuals who have some type of cognitive um, impairment, they have an inability to process environmental stimuli, so they can suffer from what they call sensory deprivation. um, One of the main things that I know from in the one of the main reasons that they say when you have FTTs, which is failure to thrive, people who don't thrive, people, especially the children that they diagnose with failure to thrive, they say that is because of lack of a lot of time environmental stimuli. And then once you start playing and giving them food and showing them love and caressing them children gain weight, they become more active and everything, and they've proven this effectively that this is something that contributes. Factors that contribute to sensory alteration. Okay, sensory alteration is, of course, perceptual, how you perceive and see things. So a person that is getting hallucinations, that is not hallucinations. It may be from drug use. It may be from some type of mental problem. They have a sensory alteration, cognitive, how a person, or how the information is coming into them, or their understanding. And that's people who have difficulty with memory, maybe somebody that has Alzheimer's disease or something, problem solving and task performance, maybe somebody with some type of mental problem, emotional disturbances, anxiety, anger, panic, apathy, fear, belligerence, depression. Those are all factors that contribute to how a person um, receives um, or or gets information. And who are the people who one would consider more at risk of these type of alterations? Those are the people that I told you about earlier. People with cognitive impairments, people with um, various things like that. uh, Sensory overloads, increased sensory stimuli. Patients experience so much sensory stimuli that their brain is unable to respond meaningfully or ignore stimuli. Patient feels out of control and exhibits manifestations observed in sensory deprivation. So they'll shut down and everything because it's just so much going on. A big example of someone with the sensory overload are patients who are in ICU or not, because they have a lot of things going on. They have a lot of lines and different things like that going on. Factors contributing to sensory alteration: sensory deficit, impaired or absent functioning in one or more senses. Okay, So if a person is impaired hearing and sight or taste or numbness, or they got the tactile things going on wrong. Maybe they had a stroke and they have paralysis and they can't feel, and so that would be altered tactile. Maybe reversible or permanent. It depends on what the particular situation is. They occur gradually or at once and present at birth or evolve later. Factors affecting sensory stimulation, developmental considerations. Different types of sensory stimulations are needed for growth. Differences in newborns versus the elderly. That's just what I was telling you earlier when we talked about, you know, how you have the elderly people and with the uh problems, like for instance, okay, you may have like children. um they have more, um you need to engage them more, like developmentally, because they're developing muscles, they're developing coordination, they're going through those type of things. Then you have what you have the older people and stuff. Well, the older people, they may have decreased in vision, decreased in hearing, decreased sense of touch, all of these things as a result of just aging going into place. So you may have to really keep that in mind, that different things happen to older people as they lose certain types of functioning, and there may have to be different alterations in how you deal with them based on that. You may want to discourage them using a lot of sedatives and everything, because um, they may limit their cognitive function, or it may make them prone to fall, or uh, and things like that. You may have to orient people more constantly and that type of thing. um, Ethnicity, religion, income, subgroups, different things like that, or may dictate what type of sensory stimulation is considered normal. Certain people are more touchy feely than other people. That's a cultural thing. Norms within a culture all influence the amount of sensory stimulation considered normal. Personality, lifestyle, how a person conducts their life. Some people may choose to have a lot going on, and they may have a lot going on. Then there are other individuals who don't have a lot going on. Uh, Stress and illness dictates how you receive various type of stimulation in your life as well. So hospitalization, medications, you have certain medications that tend to decrease the amount of central nervous system stimuli that a person uh, may take. Some medications contribute to impairment of sensory functioning by decreasing how much reception that we have. Stress, physical illness, pain, everything that goes on with you in life tends to affect how sensory stimulation in some form or some way. The nursing process for sensory stimulation. So we're going to go through uh, various types of care plans, as I can say, or types of things for the nursing process as far as sensory stimulation is concerned. Okay, so in order to assess sensory experience, stimulation, reception, transmission. You go through all your processes when you're assessing for these type of things in individuals. So you're going to go and you're going to do your physical assessment first, and assess various factors related to reception transmission, and do physical assessments related to each of the various type of senses that I told you, like the gustatory, the tactile, the olfactory, all the different types of senses that I related to you earlier. Okay, you're going to assess those, because when you do your assessment, you go right down the list and you go, this is a way of us showing you, how you perform a regular physical assessment. You're going to diagnose whatever things that you find or you see with that person that may be a problem or may cause them some type of disturbance, or may prevent them from maybe even going through a healing process is good. So you're going to diagnose the problem and or etiology in relation to the sensory disturbance. So you'll have a disturbed sensory perception. That is the beginning of a nursing diagnosis, and it's going to be related to whatever. And then it's going to be as evidenced by them doing whatever. You know, you can call them acute chronic confusion, can be a nursing, the beginning of a nursing diagnosis. Impaired memory, altered environmental stimuli, altered sensory reception, psychological stress. These are all nursing diagnoses that you'll find in your book. And what I would tell you, guys, is to be familiar with these books, with these nursing diagnoses, because there have been times, and you can find the NANDA nursing diagnosis that go along with disturbed sensory perceptions on page 1587, because there are times when, and it gives you examples of sample defining characteristics of when it's like nursing diagnoses that are what can I say, that goes along with certain types of symptoms that you would see. So you would know, which ones to use and which ones are more appropriate. The nursing process for sensory stimulation, the outcome. So you're going to developmentally stimulating and safe environment. So you want a level of arousal enabling brain to receive and organize stimuli, intact functioning of the senses, orientation to time, place, and person, respond appropriately. So those are the type of things that you want to happen to the patient if you think it's something that you can achieve, if you think it's something that is like believable, that you can have happen or be the when you're planning that can potentially be the outcome. And so you're going to implement various things that you're going to do for the patient based on whatever you think, their problem is. So, like for instance, preventing disturbed sensory perception and stimulating the senses. You're going to control the patient's discomfort whenever possible, offer care that provides rest and comfort. You're going to be aware of need for sensory aids and prosthesis. You're going to use social activities to stimulate senses and mind, enlist aid of family members to participate in or encourage activities. You're going to encourage physical activities and exercise, and you're going to provide stimulation for as many senses as possible. Now, like for instance, when you provide stimulation, that's mostly for people when they have some type of sensory deficit. So these are just like examples of us giving you various things that you would do for a person, and it would go when you would implement it when you have somebody that has oversensory stimulation, or someone who possibly has a deficit. Stimulation. Okay, now we're going to go, how do you assess for a person who may be having some type of problem with their senses. Uh, we're going to go from the implementing what type of things you would do. Like for instance, maybe you're trying to work with someone that has a sensory deprivation, and so then what you would do is you may want to teach them or do things to help stimulate that individual. So you may teach patients and significant others methods for stimulating the senses. You might have them participate in like some type of little board game or something like that, or something that doesn't require a whole lot. You would do it in like little bitty steps. You would teach the patients with intact and impaired senses self-care behaviors, and you would do little things, little steps. You would interact therapeutically with patients with sensory impairments. Remember earlier I instructed you guys that you always correct. You don't let them just continue. Like if you have somebody that have a memory problem or something like that, you don't continue to let them say or do things wrong. You kind of like gingerly correct them or tell them the right way. Don't say no or no, that's not right, but you would just kind of correct that individual. Okay, so how would you care for a visually impaired patient? You would teach the patient self-care behaviors to maintain vision and prevent um, um, blindness more. Maybe the fact that they're losing their vision may be related to some type of disease process. For instance, let's say you got somebody that is a diabetic and they're suffering from diabetic retinopathy. Well, the main thing that they can do is to try to maintain as normal as blood pressure, blood sugars as possible. That would like lengthen the time that they would have that they wouldn't have as many complications with that type of process. If you come in and that person is already visually impaired, you want to acknowledge your presence in the patient's room. You always want to speak in a normal tone of voice. Just because a person can't see don't mean that necessarily they can't hear. You're going to explain the reason for touching the person before you're doing something, because you don't want to startle that individual while you're doing whatever procedure or whatever you're doing, even if it's taking vital signs or whatever. If you know that that person is visually impaired, you want to alert them before you place your hands on them. You want to orient the person to sounds or whatever is going on in the particular environment. Caring for visually impaired patients, you want to orient the person to the room arrangement and furnishings, depending on how long that individual have had problems with their vision. They may be real familiar, especially if you're going to their house, and a lot of times they tend to have things in pretty much of a orderly uh way put together, because they know just where they keep everything. You're going to assist with ambulation by walking slightly ahead of the person. You're going to stay in the person's field of vision if he or she has partial vision, and you're going to provide diversion using other senses. A lot of times, they always say that when a person is missing one sense, their other senses become more heightened. You're going to indicate conversation has ended when you're getting ready to leave the room. So when you're going to leave the room, and especially if a person totally cannot see you, you're going to say, okay, well, I'm ready to leave the room now. I'll be back in a little bit, and then if you come back, you're going to announce that you're coming back. And that's for people who are without much vision at all. When you care for a person and you have a person, for instance, with a sensory deficit and it's from hearing, you want to teach measures to prevent hearing problems. You want to orient the person to your presence before speaking. um, you want to decrease the background noises before you speak so that they can hear you. Always check the patient's hearing aids. I have found that in the past, when I've seen people and they have problems with hearing loss, a lot of times we don't take the time to check that their hearing aids are acting the right way for them. You're going to position the self so the light is in your face, because a lot of times people who can't hear well, they are very good at reading, at, if they can hear a little bit, and they're good at reading what you say by sight. So you're going to talk directly to the person while facing him, and if you are able to use sign language and you're appropriate and know how to do that, that's okay to do as well. And write any ideas you cannot convey in another manner. Feel free to use pencil and paper. um, when you have children, you're gonna make sure that they have their hearing checked yearly. We're gonna tell people to avoid using loud machinery and that type of thing without earplugs. You're gonna avoid cleaning the inner canals of your ear. And if a person has any ear pain, have that checked as soon as possible by a practitioner. uh, let's say you have another deficit, for example, someone who has a patient who is confused. You may want to use frequent face-to-face contact to communicate social process. You want to speak calmly. You want to simply direct the patient. And remember, I told you always orient and reorient the patient to the environment. Always orient the patient to the time, place, and person, and you're going to communicate with that person. Is expected to perform any type of self-care activities that's like reasonable for that individual. You want to offer explanations for the care, and you want to reinforce reality if patient is delusional. So if a person has some type of fixed false belief about something, you want to always, like I told you before, correct that individual. Communicating with an unconscious patient. Be careful what is said in persons present, because just because a person is unconscious, that does not mean necessarily that their hearing isn't intact, because usually they say the hearing is the last thing sense that is lost. You want to assume the person can hear you and talk in a normal tone of voice, and speak to the person before touching. And you also want to keep whatever environmental noises that the person have at a low, pretty low level. Okay. Chapter 25 is the health assessment. The chapter 25 learning objectives is to explain the purposes and types of health assessments, follow guidelines for conducting a health history. We're going to prepare the patient and the environment for a health assessment, identify the equipment and positions used during a physical assessment. We're going to use the techniques of inspection, palpation, percussion, and auscultation during a physical assessment. Conduct a physical assessment in a systematic manner. We're going to document significant health assessment findings in a concise, descriptive manner. And we're going to lastly describe nursing responsibilities before, during, and after various diagnostic procedures. What is the purposes of the health assessment? The purpose of the assessment is to establish the nurse-patient relationship, to gather data about the patient's general health status. You have what they call subjective and objective data. Um, the differences between those type of data is that, of course, the subjective data are experienced, or they're known only by the patient. So, for instance, pain and nausea. That is an example of a person having subjective data. Objective data are directly observed or elicited through physical examination. So, for example, any type of um, examination that we see, or if we're looking and we see a lesion on a patient or something like that, that's an example of something that you notice that's considered objective data. Also, you taking a person's blood pressure, that's considered vital signs, and you're obtaining them objective data. You want to, when you do a physical examination, you always want to identify a patient's strengths. What I mean by that is to identify, the things that's positive about the patient. For instance, they have a very supportive home environment. That is considered a strength. Identify actual and potential health problems. Actual problems are problems that okay, I know this person has hypertension. Potential problem could be the fact that this person could be prone to having a stroke because of the fact that they are tend to not keep their blood pressure under control, or maybe that person is obese, and a potential problem could be other health conditions because of the fact that that person is obese. And then you want to establish a base for the nursing process. So the purpose of the health assessment again is to establish the patient nurse relationship, gather both subjective and objective data, identify whatever patient strengths you have, identify actual and or potential health problems, and then establish a base where you're going to start for the nursing process. So, types of assessments. A comprehensive assessment. A comprehensive assessment is considered what they call an initial assessment. A comprehensive assessment with a health history, and it usually has a complete physical examination, and it's usually conducted when a patient first enters a healthcare setting. And this information also provides a baseline for comparing later assessments. Okay, then you have ongoing partial assessments. They're conducted um, at regular intervals at the beginning of each home health visit or each hospital shift or during care of the patient. This type of assessment concentrates on identified health problems to monitor positive or negative changes and evaluate the effectiveness of interventions. Does that make sense to you? So basically what you're doing, ongoing partial assessments, is when you have a patient in the hospital, you may be dealing with one thing that you're really looking at, or you may be saying, oh, last night I gave this patient this because their blood pressure was up. Let me check and see now if I need to make any changes, because did that have an effect? Did this insulin bring their blood sugar down? Did we change the diet? So you're always doing ongoing partial assessments on patients, no matter what. Then you have another type of assessment. So first of all, we talked about the comprehensive assessment, the ongoing partial assessment. Another type of assessment is a focused assessment. The focused assessment is conducted to assess one specific problem. With, for example, if a woman is having abdominal pain, the nurse asks questions about urinary problems, bowel problems, allergies, menstrual history, or things like that, because you're thinking about um, one type of assessment related to that abdominal pain. Then you have what they call emergency assessment, and this assessment is to determine potential fatal situations. And another name for the emergency assessment is called the rapid focused assessment. For example, assessing the airway, breathing, circulation before beginning uh, CPR is part of an emergency assessment. Health assessment preparation for the patient. Okay, so when you're doing health assessment preparation for a patient, you want to consider the physiologic and psychological needs of that particular patient. You want to also, so you want to know whether or not that patient has pain, whether or not that person may have what decreased stamina because of their age or the illness. You want to look at them so physiologically, you want to look at those type of things. Psychologically, you might want to be looking at whether or not that person has increased anxiety related to the assessment. So you're going to always explain the process to the patient as you're going along. You're going to explain that physical assessments will not be painful so that you can decrease the patient's fear and anxiety if that's what they have. You're going to ask the patient to change it to a gown and or empty the bladder if it's necessary, and you're going to answer the patient's questions directly and honestly. You're going to always use your therapeutic communication skills when you are talking to the patient, which means that you're going to use what we call the open-ended questions. And these open-ended questions give the patient a chance to talk more about what's going on with them. And you don't want to ask them questions that are threatening or negative during that period of time. You also going to make sure if, and we're mainly talking about people when they're in the hospital, you want to agree upon a time for the assessment. The time should not interfere with the patient's meals or daily routines or visiting hours. You're always going to make sure the patient is as free of pain as possible prior to your assessment, and you're going to prepare the examination table. You're going to provide a gown, a drape for that patient, and you're going to gather the supplies and or instruments needed to, and you're going to provide a curtain or screen if the area is open to others. So we're always going to make sure that we have them in a private situation. You're going to maintain cultural sensitivity, so you're going to consider cultural risk factors, um, and normal, any type of normal racial variations that people have as far as skin, um, color, or beds, nail beds, or mucous membranes, or anything like that when you're examining them would be different. Two components of a health assessment. There are definitely two different types of components to a health assessment. You're going to do the health history and you're going to do the physical assessment. Okay, the first part, the health history. The health history focuses on interviewing skills. So when you do, you're gonna collect that subjective data, and you're gonna identify risk factors. Have you noticed that they just said the subjective data, the stuff because of the interviewing, things that the patients are telling you? Identify any type of risk factors from obtaining the subjective data. Factors to assess would be biographical in nature data. So biographical, where do they live? What's going on with them? That type of thing like that. Name, address, gender, where do they work? Religious preference. Those are ideas and different things that affect the patient that is considered uh, uh, biographical. So you're gonna And you're gonna look at why that person is seeking health care. For instance, be sure tell me why you're gonna ask them. Tell me why you're here today. Don't suggest anything to the patient. Let the patient tell you why they're here. Um, you're going to history of present illness. They're gonna tell you when it first happened, uh, what they was doing when the situation happened, uh, what exacerbates the problem, what makes the problem better. Okay, they're gonna tell you their past medical history. They're gonna tell you about childhood illnesses, uh, what type of things they're allergic to. They're gonna talk about any type of accidents, injuries, surgeries, and if they're on any type of prescribed medication. They're also going to talk about family history, like if their parents had a risk of cancers or any other type of chronic illnesses. And then they're going to also talk about, how they lead their life on normal day, how much sleep they get, what type of things they do. Okay. The other form of assessment that a person would do would be a physical assessment. Doing the physical assessment, you're collecting objective data. Like, now, remember, like earlier when I told you about the health history, we're collecting subjective data, and with the physical assessment, you're collecting objective data. So you're actually doing a full physical assessment on that person. You're going to collect objective data. You're going to do the head to toe sequence or system sequence. So you're going to do what they call the general survey, where you're going to look at them from head to toe, do their height, weight, take their vital signs. uh and you might look at just, like their hygiene, their posture, their gait, even thought processes, just the general survey. Then you're going to look at their integument, their skin, head and neck. uh um you're going to do the thorax and lungs, cardiovascular, peripheral vascular, abdomen, male, female, genitalia if possible, and then musculoskeletal. So there are going to be different things that you're going to check when you're checking each system. You're gonna make sure that like even when you do the integument, you're gonna always make sure that you have on gloves. You're gonna inspect the color and lesions and palpate for temperature, texture, moisture. You're gonna look in their hair. You want to see if a person has unusual growth or lack of any infestations. You want to look at the nails for color and condition. Nails are a part of the integument. Also, when you do head and neck, you want to look at the Snellen chart, ophthalmoscope, otoscope, tongue depressor. You looking at their teeth. You looking at their ears, nose. So we're gonna go through all the processes and everything as far as a physical assessment, because you guys are going to be presenting a physical assessment. And I think, if I'm not mistaken, that's what we're going to be doing Friday in lab as well. The stethoscope, equipment used during a physical examination. You're going to do stethoscope, used to listen to the sounds of the heart and the lungs. You got two different parts of the stethoscope. You have a bell and you have the diaphragm. The bell detects low pitch sounds, and the diaphragm uh, detects what they call high pitched sound. Then you have what they call the ophthalmoscope. And here's a picture of the ophthalmoscope. And it visualizes the inner structures of the eye. And a lot of times people don't pretty much know too much what they're looking at unless this is an area where they're looking at that area all the time. A lot of time you'll have a ophthalmologist or optometrist looking at those areas to find if there's problems within the inner structures of the eyes. Then, okay, next is the otoscope. The otoscope examines the external ear canal and the tympanic membrane. A speculum which is attached to the body of the otoscope directs the light in a narrow beam to improve visualization of the ear structure. Mostly nurses look at that to see maybe how much cerumen, or if particularly someone may look like they may have an inner ear infection. So that's one of the materials that you would use. The most important thing is to make sure that you get the proper size for a person's opening in their ear when you're visualizing. Another instrument used during your physical examination would be the use of the otoscope, and that's to examine the nasal cavity. So you're basically looking in there to see if there's any obstruction, if the person has any swelling. Sometimes individuals have sinusitis really bad, or a deviated septum, or something of that sort going on. Also, one of the main things that you would use when you visualize and you're checking for distant vision is the Snellen chart, and then lastly, the nasal speculum. So you want to find out whether or not a person may have any problems with their nose, if they have any type of nodules or anything like that that's obstructing their breathing. And then lastly, we have what the vaginal speculums that'll usually be used by a physician or a nurse practitioner to give vaginal exams. And the tuning fork that tests auditory function and vibratory perception. And then lastly, the percussion hammer, which is the reflex hammer, which tests deep tendon reflexes and determines how dense the tissue is. Okay. There are several positions that are used, and I know in the past that if you look on page 567 of your textbook, chapter 25, I want you to be familiar with these particular positions. Um, One of the positions used when performing a physical assessment would be sitting. So you would sit on the chair or the side of the bed. Also, you can have a person what they call supine, and that is flat on their back with their legs extended and knees slightly flexed. Dorsal recumbent lies on the back with the legs separated, knees flexed, and soles of feet on bed used for patients having difficulty maintaining supine position. Maybe they having pressure, maybe they having a particular area like their back or whatever that may be hurting. Just laying flat may have them with a problem. Then standing, which is erect, able to assess posture, gait, whether or not anybody has curvatures of the spine or something like that. You have the Sims assessment that's on that left side. A lot of times when a person is lying and you want to assess them like that, that's usually used to assess the rectum or the vagina. And then prone lies flat on abdomen with head turned to one side, and that's able to assess hip joint and or any part of the posterior thorax. Um, Lastly, you have the lithotomy, and that's basically used for women mostly when they're getting their pap smears or they're getting some type of vaginal exam. Then you have the knee chest assessment of the rectal area is used for usually a brief period only. So you have several techniques that you used for physical assessment. This would be an area where you would be tested and required to know the difference between these type of ways to assess during a physical assessment. The first one is inspection. During inspection, it's the process of performing deliberate and or like purposeful observations in a systematic manner. The nurse observes visually, but also uses hearing and smell to gather data throughout the assessment. Inspection begins with the initial patient contact and it often continues through the entire assessment. So you observe visually using hearing and smell, and you're basically just gathering data. You During inspection, you just make sure that you notice if there's anything normal or any type of deviations from the normal. Then next, you would notice techniques used during a physical assessment again is palpation. Palpation uses the sense of touch. The hands and fingers are sensitive tools and can assess skin temperature. You can assess skin turgor, and moisture, textures, vibrations, all types of things, shapes of structures within the body. So you also could listen to vibrations within the heart, shapes of the bone, like I said, the temperature. You'll look at figure 25-4, and you could tell people use palpations and they showing the main areas. uh, People use the left palmar surfaces of the examiner's fingertips, and then they showing the dorsum or back of the head is used to assess maybe a temperature, as you can see as well on the screen. Okay, and so they may use the difference between that too. The difference between what the dorsum surface of the hands assess and the palmar surfaces. The difference when you're palpating as well, a light palpation is considered 1/2 inch, moderate is 3/4 inch, and deep is 1 inch. Techniques used during a physical assessment is percussion. Percussion, I don't see it being used quite as much as the other two from nurses, but percussion is the act of striking one object against another to produce sound. And basically, when you use, I've seen physicians do it more. The sound waves produced by the striking action over the body tissues are known as percussion tones, and percussion is used to assess the location, shape, size, and density of tissues. So both hands are used to produce sound waves. The nurse's dominant hand is placed directly on the area and then with the fingers lightly separated, and then the middle finger is placed firmly on the body surface. The other hand provides the striking force initiated by a sharp downward wrist movement with the forearm stationary and the wrists relaxed. So that's how you do, and they usually say that based on the quality of the sound, they can notice what is going on. Um, like as far as with, percussion, various percussion tones. Like for instance, when you during the time that you percuss, if you look on your book, um, page 569, it says like a flat tone is a thigh, dull, medium, liver, resonance, loud, normal, long, hyperresonance, very loud, emphysematous lungs, and then tympany, loud, gastric air bubble, or puffed out cheek. So they telling you what type of things to listen for, and a lot of times you have to be really versed or familiar with doing that type of process. It gets better with time, to find out, what's going on and how to use that type of process. And then auscultation is one where basically we are more versed at as nurses, is auscultating, and it's the act of basically just listening with a stethoscope to sounds produced within the body. You have four characteristics. You have the pitch, the loudness, the quality, and the duration. I would suspect that you would know the difference between the pitch, loudness, quality, and duration, and we're giving you examples of each. Then you will do your general survey. Inspect body posture, build and gait, note symmetry, erect or slump, observe hygiene and grooming. Note signs of illness such as changes in posture, skin color, respiration. You could just look at a person, and remember I told you with time you will be able to assess these qualities. Then you're gonna do the vital signs and assess the baselines. One thing about one person may not be the same for another. A lot of times they talk about how athletic people tend to have more lower pulse rates than other people. They may be in the 50s, and that may be what they are. That may be what their normal range is. If you're weighing a person, you're going to do the weight in kilograms, and you're going to make sure that you're going to use the same scale, because and remove shoes and heavy clothing when you're weighing a person. And you want to try to get as accurate excuse me, as possible when you are working on an individual. Skin. Okay. You're going to inspect the skin color, and that varies among races. You're going to inspect for erythema, cyanosis, jaundice, and pallor. I want you to know what the difference is between erythema. I want you to know what the difference between cyanosis, jaundice, and pallor. And them people possessing those type of characteristics, what exactly does that mean? Erythema, redness of the skin. Okay. Then you have people with jaundice. That's a yellow color of the skin. Um, then you have someone and they got pallor, which is a paleness. Cyanosis, a blueness. What does these things exactly mean when a person have these colors? Does cyanosis mean lack of oxygenation? I want you to make sure you're studied on that. Okay. Then they may have some type of what they call vascularity, which is ecchymosis or petechiae. Ecchymosis is a collection of blood in the subcutaneous tissues. And it'll come out looking a certain way, purple, lesions, palpate for temperature, moisture. You want to see how elastic the skin is. Old people may not have real elastic skin because that's one of the signs and one of the things that old people tend to lose is elasticity as they get older. So you need to be able to know that that may be a normal occurrence for older people. Texture, dry, loose, and wrinkled. Nails, shape and angle, texture and color. Smooth, non-tender, no indentations, infections, and clubbing. I want you to make a note of all these things as we go along. Hair. Hair, color, texture, and distribution. No alopecia, uh, hirsutism, and hair loss. I want you to know what is hirsutism and alopecia. What are those two different things? And what type of things could cause that? I'll give you, it may be some type of hormonal disorder that could make a person have alopecia or hirsutism. So I want you to know what those two things are. Scalp, you want to notice the color, dryness, scaliness, lumps, lesions, lice. All of these type of things when you're inspecting a person is something for you to know. Then edema may result from overhydration, heart failure, kidney failure, trauma, or PVD. PVD stands for peripheral vascular disease. It ranges from trace to very deep. I want you to be able to know the difference, or at least be able to say that this person has trace, or this person has pitting versus non-pitting edema. What is pitting? What is the difference between that? What does that mean? Um, I told you guys earlier that it's very important for you to know that people have related to their age difference or variations that are a normal thing. In infants and childs, they have jaundice and whiteheads in the newborns occasionally. Lanugo, the first 2 weeks of life. What is lanugo? Smooth, thin skin at birth, pubic hair at onset of puberty. These are normal variations. Older adults, wrinkles, dryness, scaling, decreased turgid. I mentioned that earlier. Sometimes they'll have flat brown age spots, raised dark areas, hair loss, fine brittle gray or white hair. Sometimes they may have thick yellow toenails, old people, because their circulation gets a little bit less as they age. Characteristics of mass is determined by palpating. So when you palpating, you want to inspect for any type of characteristics of any type of skin lesions. They have macules and patches and papules and plaque and nodules, and I mean, these are different types of things that they got. If you look on page 573 of the textbook, and it goes all the way up to 575. It kind of defines, like, for instance, you'll look on 574, it talks about wheals, and that's like a hive or a mosquito bite or a vesicle that started from a herpes simplex. So a pustule from acne or impetigo. So there are different characteristics and different ways that various type of nodules and stuff look, and as time go on, you'll learn the difference between these and how they look different, and whether or not this is considered something that is like, okay, that's not to be concerned with. in the skull. When you're doing the head and the neck and you're looking at the skull, you want to make sure that it's symmetrical size and shape. I mean, if you look at a kid, um usually their head circumference should be measured up to 2 years of age. A lot of times kids have big heads, you know, as opposed to an adult having a big head. But at the same time, you want to make sure that a child, you want to make sure that their head is not like a hydrocephalus or something like that, something that's like really, really, really not what it should be, you know. Um, Note if they have any periorbital edema, involuntary facial movements, like, or anything like that. So you want to assess the eyes, external and internal eye structures, visual acuity, and how are you checking visual acuity? You're going to use the Snellen chart, extraocular movements and peripheral visions. So you're going to do various types of tests to test whether or not these things are going on. You're going to test pupillary reaction size and accommodation and convergence. I want you to know the difference between accommodation, reaction size, and convergence. I want you to know how do you check accommodation? Are you checking accommodation by moving something closer and out? Um, I want you to be able to show us how to do that. Because a lot of times people are chart, but they won't know exactly what they're doing. Inspect symmetry and parallel alignment, drooping of the eyelids. Sometimes people have what they call ptosis, ptosis, which is a drooping of the eyelids. That is correct. You can correct that with surgery. So you're going to inspect that as well. And sometimes if you may not necessarily know everything that you're looking at, but a lot of times you'll know what exactly is or isn't normal, okay? For you to be able to at least report. You're going to assess the ears, and remember I told you guys symmetry and proportion to head, note pain, edema, lesions, infection. You're going to assess the noses and the sinuses. We talked about this early. I said note if there's swelling, bleeding, discharge, any polyps, any lumps, anything that just doesn't look normal. You're going to look at their mouth and their pharynx. You're going to notice if you see any swelling or lesions. You're going to assess the tongue and assess to see whether or not the tongue is a funny color. Sometimes a person will have a real bright red tongue, and I know it may seem like it's something different, but they'll have a real bright red tongue, and that might mean that they have anemia. Sometimes people have thrush on their which is candidus. They'll have but like a white cloudy infection on their tongue. You want to notice whether or not that person has loose caps or dentures or something like that going on that's this inhibiting them from functioning in the manner in which they may need to function. Okay, so you're going to assess the trachea, the thyroid gland, and the lymph nodes when you're assessing the the uh trachea. And I want you to just take a look at it and see like if it look like it's sticking out. Sometimes when a person has problem with their thyroid, they have a nodule or their neck look like it's malformed. There's an approach on page 585 on 25.6 about palpating the thyroid gland. You got a posterior and anterior approach. I'm going to have everybody um, uh, demonstrate doing this stuff in class. Okay? So we'll do that. Inspection. You're going to observe chest for color, shape, breathing patterns, and muscle development. You're going to note the chest symmetry, transverse versus anterior posterior diameter, 2 to 1. So basically, what they saying, what you see, the transverse and the anterior posterior diameter should be 2 to 1. So basically, when a person stand like, for instance, to the side, it shouldn't be as big as when they're standing in front of you. You know, because that means a lot of times that's a result of a person maybe possibly having some COPD. Um, Palpation, you're gonna observe the chest for color, shape, breathing patterns, and muscle movement. That's doing inspection. Then when you do the palpation, you're gonna detect areas of sensitivity, chest expansion during respiration, and vibrations or fremitus. uh you're gonna let us know what the vibrations and the fremitus mean. Is there some type of vesicular breath sounds or adventitious breath sounds that aren't the right type of breath sounds? You're going to have increased consolidation, COPD, decreased pneumothorax. I mean, that's those are the type of sounds and stuff you get is with those particular type of breathing patterns. So you're gonna note those type of breathing patterns when you're doing the physical exam. Also, percussion you're gonna use to determine lung position and size and detect presence of air, liquids, or solids within the lungs, and that goes by how the pitch is. I can admit that I'm not real good at doing that, so it just comes with time, you guys, and us just determining what the when you're percussing what these sounds are. And I went over this a little bit earlier about the types of sounds heard when percussing: flat, dull, resonance, hyper resonant, and timpani, and what's the difference in these sounds. I would urge you once again to make sure that you know about them. Auscultation, and of course we already talked about what auscultation is. Characteristics of sounds, we already talked about that earlier. Adventitious breath sounds. Adventitious breath sounds: crackles, intermittent sounds occurring when air moves through airways that contain fluid. You have wheezes, rhonchi, and pleural friction rub. I would say that it's probably very important for you to know the difference between these sounds and what this means when you're uh what type of I would, if I was you, I would say that I would want you to know what type of possible, maybe learn one disease process or one thing that's going on in the body that results in a person having that type of sound. If you look on table 259, 590, it'll tell you, it'll describe an illustration and what that means. Excuse me. So, okay, pattern used for palpation, percussion, and auscultation of the chest. As you can see that you're going um as you can say, you're going from side to side, side to side, down, over side to side. And the reason why you're doing it that way when you're auscultating is because you're trying to compare the sounds of with each other. You don't go all the way down one side and then all the way down the other side. You want to compare how they sound in relationship. There are common cardiovascular and peripheral vascular variations in newborns and children. They have a visible cardiac pulsation because their chest wall is thinner. They have sinus dysrhythmia. The rate increases with inspiration and decreases with expiration. When you're looking at a child, sometimes they have a presence of a S3, which is a third kind of heart sound that sounds like love dub d, and that's like a current recurring in about a third of all children. And then usually they have a more rapid heart rate up until they get about 8 years old. The difference between older adults is that an older adult, it's difficult to palpate their apical pulse, difficult to palpate their distal arteries, dilated proximal arteries, and they usually have a lot of varicosities, which means varicose veins, and they increase systolic and diastolic blood pressure, and then a widening pulse pressure. And a lot of these things are just the result of the fact that the people have been out here a little bit longer, you know. I would like for you to think about and know what the difference is between Allen's test, Berger's test, and the proper way to assess a capillary refill. Physical assessment: measure blood pressure and assess peripheral pulses and perfusion. You're going to check the neck and pericardium. I want you to be able to recognize your areas. Over here, you can see the pulmonic, Erb's point, tricuspid, mitral, and mid-clavicular and mid-sternum. I'm sorry. Excuse me. Observe and palpate for visible pulsations. Note neck vein distension and visible pulsations, which is not supposed to be the case. And you should be able to auscultate that and identify any precordial thrills. Thrills is a feeling when you auscultating um, the chest. And I don't want you to go into like a whole lot of, because you're going to have plenty time to do cardiac, but just want you to know just the basic area. Know what aortic, pulmonic, Erb's, tricuspid, mitral, and mid-sternum and mid-clavicular lines are. Show me on the patient and what that means. When you're assessing the peripheral vascular system, which basically you're looking for tissue perfusion. A lot of times you're trying to make sure that the heart is pumping all the way out to the toes, all the way out to the fingertips. And a lot of times that's the reason why as times get as a person gets older, this tends to decrease. I went over the areas and the different normal age variations. I think I kind of skipped over myself a little faster. Um, Inspecting breasts, you're going to note any retraction or dimpling, note lesions, asymmetry. A lot of times women may have areas where one of their breasts may be a little bit slightly larger than the other. You're going to check with a woman to make sure that she's doing her normal breast examination. um, you want to know what type of way would you think that a woman would lay when you do a breast examination. What would you do? Uh, what when if you're the one palpating, what type of way would you think would be better? What position? If you look at on page 595, what do you call that position that you see that lady laying in? And I've seen them ask that before, even in the exams. You want a breast tissue should be smooth and firm with granular consistency. Some people tend to have more fibrocystic breasts than other times. You want to instruct the female about when it's the best time for them to perform their breast exam. Um, Normal age related and stuff like that, variations as far as with the female. A lot of times they have breast enlargement and white discharge from the nipple up to 2 weeks of age. Female breasts grow between 10 or 11 years of age. Sometimes pubescent boys might have some gynecomastia or some slight enlargement of the breast for a moment and then it goes away. You want to know that a lot what's normal and what's not, like not normal. You want to notice this. Usually the breast, if it's like the week or so before a woman menstruates, a lot of times there will be some slight tenderness noted on the breast. Check for the lumps, tenderness, nodules. I told you about the normal variations. Inspect the abdomen. Oh, this is a good one. A lot of times when you're inspecting the abdomen, you're going to do the color, surface characteristics, symmetry, peristalsis, pulsations. Note whether or not they have any stretch marks, any type of things. You're going to check the bowel sounds. You go causes for hypo or hyperactive. For hypoactive bowel sounds, it's generally post-surgical people have hypoactive bowel. You're going to percuss the abdomen because there are normal areas and normal quadrants. Right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. I want you to be able to tell me what is in what quadrant. Or you're going to on the right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. What areas or what things are in those particular quadrant um, when you assessing or palpating the abdomen. How long are you going to assess bowel sounds? What's normal? What quadrant in your book? How long are you going to auscultate for bowel sounds? I want you to know those type of things. Percussing the abdomen. So you're going to go systematic clockwise manner to identify any type of masses or air or anything like that. You're going to use pads or fingers to palpate with light dipping motion. If complaining of pain, you're going to palpate that area last. Even though you may be going in a systematic motion and you may start like I'm going to start on the lower left quadrant and I'm going to go up and this or the right upper quadrant and then go to the left upper quadrant. But if let's say the left lower quadrant is hurting, you're gonna skip and go to the other side. You're gonna go always do that. Usually, normally the liver, you should not be able to palpate that unless somebody is having some problems or have a really bad history. So right here, I showed the picture of the areas where I want you to know and how they're identified and where they're located on the abdomen. Inspect and palpate the external genitalia. Of course, you got. We won't necessarily. You may look but you may not necessarily palpate or be doing all that. You may just want to inspect or ask the person subjectively if anything is going on with them, and leave it to the physician to examine them with you in the room. Okay. Uh, there are some normal variations in female genitalia. They say that the clitoris and labia at birth are enlarged, pubic hair and breast development at puberty, menstruation 2.5 years after puberty begins, older adult decreased labia, size, pubic hair, and vaginal secretion. So those are the differences between a female genitalia. Same thing with the men, and you can read about the inspection and the appearance and redness, edema, discharge, whether or not the person is circumcised or non-circumcised, and whether or not they know how to properly clean themselves. I mean, there are a lot of little different ways that you can do a lot of teaching, as far as people taking care of themselves and doing the right things and noticing if there's anything going on. Okay, pubic hair at puberty for a male genital. Usually a man has a spontaneous nocturnal emission of seminal fluid as they get, which is basically what they call a wet dream or something. Spontaneous nocturnal emission of seminal fluid. Uh, you hear about that in males as they start growing up and going through the puberty phase. Um, very common in men. Um, older adult as they get older, the decreased penis size, pubic hair, and size of testes. So you know that this is supposed to be normal. So if you see something different, like if you see a testes that's real big or enlarged, then you may be saying to yourself, maybe this person got a hernia or something. I've seen that happen before, or something like that. You're going to inspect and palpate muscles, test muscle strength and tone. You're going to know atrophy, tremors, flaccidity of muscles, decreased range of motion, pain, and swelling. This is when you're assessing the musculoskeletal system. You're going to palpate the bones, contour, prominence, inspect and palpate joints. You want to assess whether or not they have movement, flexion, extension, hyperextension, abduction, adduction, supination, pronation. All these things is what you want to assess. Inspect spinal curves. Um, See, there's definitions of kyphosis, lordosis, and scoliosis. I want you to know what the difference of that is, and it's very common. The kyphosis is especially in older adults. Like it looked like a little hunchback. So basically what I wanted to say to you was that there are some normal variations um, in older people. Infant child tends to have a C-shaped curve of spine at birth and a little bit of lordosis. Um, Pronation of feet at 12 to 30 months. Pronation. Know what that is? Is that when you stick your feet and go inward, or is it when they go outward? Bow leg 1 year after learning to walk. Older adult, loss of muscle mass and strength, decreased range of motion, kyphosis. I told you about that, and they usually should have decreased weight. Usually that happens as people get older. Okay, then you're going to do the mental status. You want to see whether or not the person is aware. You want to know whether or not they are aware of their mental status, cranial nerve function, motor and sensory function. You want to know whether or not this person is aware of everything that's going on. Mental status, level of awareness, level of consciousness, behavior and appearance, memory, abstract reasoning, and language. Note poor hygiene, inappropriate dress, whether or not the person is disoriented, they can't recall, then you'll know that something mentally something's going on the cranial nerves, you guys. I want you to know the difference between the 12 total cranial nerves, and I want you to pay attention to what type of test and why that would make sense to test that particular way for, like the cranial nerve. That's what I want you to know. So if you look on page 606, table 2511, I want you to start trying to remember, because when you get to med surge 2, you'll have to know, and I want you to just kind of start working on that now. And reflex function, evaluate deep tendon reflexes. There are processes and ways to evaluate your reflexes, and a lot of times that's very difficult for people to do. I might kind of want you to remember I was showing you, I might want you guys to um uh talk about using, like how I was showing you guys the little oh, I can't even think of the name of it, the little hammer little deal that you test the reflexes, and what the type what the basic purpose of that is, and what it means based on why how somebody reacts when they're testing that process. You know, I would want you to check. They say an infant and a child usually has what they call a positive Babinski reflex between 12 to 24, and that usually is a way of saying that they are not, that nerve is not intact, but it's very common in children, and that's that flaring of the feet of the toes open. uh but anyway, I want you to see what that's about. Older adult, they got slow thought processes, decreased sensory ability, decreased reflex response, slow great gait, decreased deep tendon reflex. Everything about a person when they get older tends to slow down, you guys. So you can be more cognizant of that when you're giving a physical exam. Okay, here is an example of what they call Romberg sign, and it detects the inability to maintain a steady standing posture with the eyes closed.
Perform the Romberg test, which primarily tests position sense. To do this, ask the patient to stand with his feet together. Normally, he should be able to maintain this posture with his eyes open, indicating intact cerebellar function. Now have the patient do the same thing for 20 to 30 seconds with his eyes closed. His posture should remain steady with only minimal swaying, indicating intact position sense. If the patient maintains this posture with his eyes open, but not with his eyes closed, he has a positive Romberg test. Now check for pronator drift. To do this, ask the patient to hold his arms forward and parallel with the palms up, and to close his eyes for 20 to 30 seconds. Normally, the patient can maintain this position, but watch for downward drifting of one arm and pronation of the forearm, which suggest mild hemiparesis.
Stay just as you are.
Finally, ask the patient to keep his arms up and eyes closed while you tap the arms briskly downward. Normally, the patient's arms return smoothly to the horizontal position.
So just be able to know why someone would do this particular test and what this particular test mean, and I want you to be aware of it, and I hope you enjoyed that. Also, then the homing signs. Now, they say now that they don't want people to do or check this homing sign now. I will show it to you guys, but they said that it checks, basically what it's checking is for deep vein thrombosis, and they are saying now that apparently doing this can cause more damage. Okay, so I'll let you see it, but know that a lot of right now we're gonna kind of eliminate and not really trip off of the home checking the home sign. But I want you guys to be aware that that's something that's out there that exists.
Holman's sign is used to determine the presence of a deep vein thrombophlebitis. The patient lies prone on the table with the knee fully extended. The examiner passively dorsiflexes the patient's ankle while palpating the calf. Pain in the calf and or pain with palpation is considered a positive test.
Okay, so then you purposes of just documenting that. So when you finish like your total physical assessment, it's very important that you guys identify the actual and potential health problems, make a nursing diagnosis, and then you're going to plan whatever appropriate care you feel is needed based on what you saw from your physical exam. And then you're going to evaluate the patient's response to the treatment. So that's the purposes of a person documenting, so that you can follow through with the patient, so you can implement the things that they need. And you want to show that you're doing these things, that the person is progressing as they should. The nurse's role as far as doing any type of diagnostic procedures is to assist before, during, and after the diagnostic test. This is important for you to know. Be responsible for other activities associated with diagnostic tests. Witness the patient's consent. Witness. Schedule the test. Prepare the patient physically and emotionally for the test. Provide care after the test. Dispose of used equipment and transport any uh, um, specimens. Okay. Any questions? Feel free to come and get any type of clarification that you may use. And I hope this audio lecture will be of some service to you. Thank you.